I think we'll probably get started.
Okay. Hi, everybody, and welcome to the call. So I'm Pamela Rennie, and Pamela Mooney, rather, it's my maiden name. I'm the Programme Manager in the Digital Health and Care Innovation Centre in Scotland. And so on behalf of Scotland and DHI and our Tittan partners from the Galician Health Knowledge Agency Exchange, the BAS Foundation for Health Research and Innovation, the Regional Foundation for Biomedical Research and Health Saxony, just like to welcome you to this first webinar in the series to exchange good practice around the COVID-19 pandemic. So this Tittan COVID project is a learning and sharing knowledge transfer project around COVID, but it does have a particular focus on healthy ageing, which we'll be looking at today. And obviously COVID has created one of the most significant healthcare crises in the last century. And the response to the pandemic has really been remarkable. And I think it's clear that the changes that we've made through the COVID response will be long lasting, and possibly some things will never be the same again in a positive way. So we saw COVID upend normal operations, expose some limitations in our systems, and on the people side it tested health and care workers physically and mentally, but out of all of this, it's created a huge opportunity for innovation to drive change, and I think that the health and care across the world really grabbed that opportunity. So today is about sharing these stories from the various types of COVID responses across a range of services and activities. And we're going to hear a real variety of presentations to transfer these ideas and help us build, the momentum for best practice and change. So just a few points on housekeeping. If all participants could ensure that they're on mute during the presentations, that would be great. And we've grouped the presentations into regions. So after each region, we'll have a 10-minute question and answer session. So please do use the chat function to put any questions on there that you'd like to raise during the Q&A session. And also, of course, any other comments you have. So the session's being recorded. So if you don't want to be recorded, just turn off your camera and mic. And thank you in advance to the presenters. So because this is quite a tight agenda and we have 10 minutes scheduled for each presentation, just to keep us on track, I'll let you know when we're at the 8-minute mark. So you've got time to wind up your presentation within the 10 minutes and we can get through the whole agenda. So I think that's really all I have to say. I won't delay any further. We'll kick off with Scotland and some of the best practice that we did here. And I'd like to welcome Mark Bezic, who's the national lead from the Near Me network. And after Mark, we'll have Jay Bradley from DHI talking about Test and Protect. And then our programme manager, Anne Wales, talking about decision support. So if I just hand over to you, Mark, that would be great. If you're able to share your screen. Thanks.
Yeah, thank you, Pam. That's great. I'm really looking forward to interacting with folk here. I'm going to just pull my slides up and we can hopefully get underway. So, yeah, delighted to be here today and engaging with people from all over different parts of Europe. So thank you very much for the invite. As Pam said, I am the national lead for Near Me, and we'll talk a bit more about that in a minute. I'm an occupational therapist by background, and previously used Near Me to connect families via video on a remote set of islands called Shetland in the middle of the North Sea between Scotland and Norway. This was all pre-COVID, and then since COVID, we've been rolling this out across Scotland. Very keen to engage with the audience today, either on the chat. We've got a couple of Twitter handles here. So there's Mark Bezic, myself on Twitter there, and also I'll just move to one side, at NHS Near Me as well for that. So very happy to have comments, questions throughout. I'd really like to get a feel for who's in the audience this morning. So if you wouldn't mind putting in, where you're from, what your profession you're in, that'd be super just to kick us off, I think, and just to get a feel for who's out there today. So what is Near Me for those of you who may or may not be familiar with it? It's a video platform that enables people to connect with clinicians via video. It's very easy to use. There's no software to install. People don't have to create a login or authenticate. It works across a wide range of devices, and it's very secure. And prior to the pandemic, we were roughly doing about 300 calls a week across Scotland. This then peaked at about 22,000 calls a week during the pandemic. Again, 90,000 a month. And we're now leveling off at around 50,000 a month. So again, it's a video platform that enables people to connect successfully with their clinicians. And in terms of successes and good practice related to COVID, it's reduced an awful lot of exposure to diseases, not just COVID, but common colds and flu as well. It's reduced people's travel to appointments, the time it's taken, the cost of traveling, the convenience or inconvenience of having to find a parking space, getting on a bus or a train, people having to take time off work, find childcare, all those issues. If you could be able to interact with your professionals via video, it takes all of those things out of the equation. And also it makes someone, if you want to have a carer or a relative or a translator join you for your appointment, they can also join you on the video call too. There's a significant environmental impact. We have every time there is a near me call, it saves the person on average 26 miles or about, I think it's about 40 odd K return journey. So we've done over 1 million near me calls, so that's something like 33 million miles of travel saved. And over 90% of people surveyed said they would very happily have another video call with their clinician. It hasn't been without its challenges. The platform capacity was a serious challenge to get things underway during COVID, but the software developers worked really hard to get that stable. And it was encouraging the adoption of remote consultations in poorly defined, less predictable conditions, things that wouldn't necessarily lend themselves to a virtual appointment or a video appointment. And it also saw staff be able to gather lots of information from someone's environment without actually having to visit their home as well. And it moved from being something that was a bit novel to something that was absolutely essential within the COVID pandemic period. And it challenged our assumptions. We assumed that certain people of a certain age or a certain disability or a certain condition wouldn't like to, wouldn't want to, or couldn't use video. And we really found out that was not the case. Technical readiness really increased. People got devices, people got connected. There was a massive culture shift, not just within clinicians, but also within patients as well. And that move from where the phone was good enough and trying to move people from the phone to something else has been quite a challenge as well. But people are getting more technically able now, and we'll talk about a little bit more a bit later on. So in terms of scale up, the kind of good practical elements of scale up that we did, we made lots of educational resources available for people. We had a really good technical team backing us up. And we had lots of local champions, people that were really adopting Near Me early on, and they became our kind of spreaders of good practice and sharing tips and supporting colleagues, and supporting their peers. We had a quality improvement approach embedded in all our development work and our change work. And also we had the power of, well, like we're doing today, webinars, where we're sharing information, sharing learning and engaging with our colleagues and peers across different parts of Scotland and also further afield. One thing that we've been acutely aware of is the digital divide. So people who found it difficult to connect with technology pre-COVID, that has been even more pronounced now. And we're having to work really hard to make sure that those people who are digitally disadvantaged are not further disadvantaged. If that person wants to join by video, but they don't have a device, they don't have broadband or data, they're not particularly skilled, how can we support those people to make that choice? So we're very keen to looking at how we enable people to make that choice, no matter where they live, whether it's rural or remote or an island, or in an urban setting. Isolation can occur within big cities and towns, not just in remote places too. We did lots of work with equality impact assessments and public consultations, and you'll see links to those in the resources at the end. One novel way that we've come across in bridging that digital divide has been community halls. So I might not be able to do a near me call from my home, but I can go to my village hall or my library or my leisure centre, and someone could be there to help me if I struggle logging on. And this is a little village hall in the remote part of Scotland, and they have a gym. They have a little gym there, they have a book exchange, they have a garden, they have a greenhouse, but they have a little room where you can come and have your near me call and have a video call in privacy if you don't have somewhere private at home as well. So we're doing lots of work with different organisations across Scotland. And I suppose what I would like to leave you with today really is, from what I've just described in terms of good practice, is, start with the person. What matters to that person today? What's their need in terms of their health? Is a video call going to be more convenient for them? Is traveling going to be an issue for them? Do they have to call on someone to give them a lift? Ask that person, would you prefer a video call? And some people aren't sure. So it's okay as a clinician to explore what's preventing you from choosing a video call if that's what you would like to do. What are the barriers that we can support you with? Do you need to find someone nearby to help you? Do you need to find a device? Could someone loan you a device? Could somebody come to your house and help you log on? So what can I do as a clinician to choose that video call and explore with that person what works for me? Because some days we have a health need and a phone call may be sufficient. Some days a video call might be perfectly acceptable, and other days in person is the only way that's going to really help meet my health need. So I would implore people to start with the person, ask the questions, and don't make assumptions. We've had some lovely stories of older people in older generation connecting with their grandchildren over devices and iPads now. I've got relatives who play bridge online who are older. And we've got lovely stories of people in their 90s using flight simulators on computers during their days. So again, it really challenges our assumptions about, how many older people can, will, and are able to use technology.
Mark, that's about 8 minutes now, thanks.
Okay, that's fine. So again, just to summarize, here's some links here. You should get them on a PDF form for you to look at later. And there's a public consultation, equality impact assessment. We have a public website for general public. We also have a professional website for clinicians who would like to access guidance, documents, and support around near me. And you can also contact us at email there as well at the bottom. And again, just to assure you, building on the work we've already done, we are striving towards near me being a consistent option for people to choose when seeking help from health services. So thank you very much for listening and watching, and I'll be thrilled to take some questions later on. Thank you.
Thanks so much, Mark. And guys, do put questions in the chat, and we'll pick it up at the Q&A session at the end of Scotland's slot. So thanks again, Mark. So I'll just pass over now to Jay Bradley from DHI, from our design team, and he's going to talk about the Test and Protect project. Thanks, Jay.
Thank you, Pam. Apologies, I was just trying to find my mute button. I hope you can all hear me and see my presentation now. Yeah. So I'm going to talk a little bit about the DHI's Test and Protect work that we did, well, beginning, 2 years ago now, I think. Several of us were involved in the work, and Kate Mark, who was involved in the work, is also on the call today. So any tricky questions, and we can pass them on to Kate, I'm sure. So first of all, I'd like to talk a little bit about why we were in a place to do this work in the first place. The DHI does lots of different things, but one of the things we do, we kind of title as the DHI Exchange. And this is a package of 3 things that we provide to partners. Firstly, it's participatory design. So if you're new to participatory design, it's the idea that if you are going to use a service as a citizen, or if you're going to have a service used on your behalf, so that's kind of, I guess, citizens and professionals, you should have a meaningful say in the development and design of that service. We also do something called simulation, where we've learned from trying to get services better adopted in NHS Scotland, but if we can simulate a service, that is actually commission the service to be built using real hardware, real servers, but dummy patient data, we can actually learn a lot more about the deployment environment, learn a lot more about integration challenges, so on and so forth. So we build simulated services. And then finally, we do something called demonstration, where we build what we would call a person-centered story. So we can take that and show it to kind of policymakers, senior decision makers in the Scottish landscape, and trying to communicate the good things about what we've done. So that's what we normally do, and that's why we were in a good position on well, when it was it now, it would have been, I'm looking at this, on the 13th of March. So 1st of March, first confirmed COVID-19 case in Scotland, I believe. On the 9th of March, Kate Mark, who's on the call with us, identified that we were going to struggle to notify even just the people who were testing negatively for COVID-19. And on the 12th of March, we held a workshop at Public Health Scotland, or Health Protection Scotland, as it was at the time, where we came together and looked at this problem. We addressed a few different problems in that workshop. There was definitely a need for some kind of notification service, so that teams like the one that Kate worked in at the time could actually cope with communicating negative results to so many people. And then we moved on to the problem with contact tracing as well. So this diagram here, it shows the key takeaway from our work really is that we designed and developed and deployed the National Notification Service in a total of 51 days. And that's from a point where Kate herself, who's on the call again, raised her hand and said this is a problem. It was a problem, across all health boards in Scotland. 51 days later, National Services Scotland was actually delivering the service which we had designed and put through development. And then the next thing we did, we produced something called Simple Tracing Tools, which was a suite of professional-facing interfaces that allowed professionals to do contact tracing in each of their boards and also nationally in Public Health Scotland. And again, when we started talking about that to delivery, it was a total of 41 days, and that was a phased rollout across all the different health boards. So that's the big takeaway from our work today, that we were able to act so quickly. And I guess the story is similar across many countries because it's all new to us, wasn't it, at that time? I don't know if we'd be able to do it so quickly now, but I'll just talk a little bit about some of those services. So everything we did was through participatory design. So we had one workshop which was face-to-face. We all crammed into a small room at Health Protection Scotland, which was possibly a bad idea at the time, but it did help us get going. And from then on, we all jumped onto virtual workshops, which we're all familiar with now, like exactly what we're still doing today. This is a diagram we put together in the very first meeting and described how a notification service might work. The details aren't important, but just giving you an example of what we actually did during these workshops. So we put this together, drew arrows, this will go here, that will go there. One of the key things for the National Notification Service was identifying this box on the far left, ECOS, which is actually a national source of all test results. At the time, it was just used for reporting and wasn't sort of a clinical service, but that's been upgraded since then. But the very fundamentals got put down right on day one here. So the National Notification Service went on. It's as of the last results, the last data I have is from August last year, so it's getting a bit old now. Currently used by 11 health boards. That's interesting. Some of the health boards are big enough and technologically advanced enough to deliver these services themselves. But the whole point of having a standard national service is that some of our health boards weren't capable of doing this by themselves. So it's used by 11 health boards as of August last year. And you can see 7 million test results processed. I'm sure that's much more now. And because we were using this to notify people of their results, we could then launch off the back of that the contact tracing service as well. So again, just to show you the kind of thing we were doing in the workshops, this is an interesting diagram to me. It's 7th of April, 2 years ago, 2020. We talked about what we would like to do for contact tracing. And you can see a little blob down in the bottom left-hand corner, testing. This workshop was done in the absence of any knowledge about Scotland's testing strategy at the time. So really intriguing that we were trying to put this sort of stuff in place, but there were still so many unknowns. So we started talking about contact tracing, how we would do it, and there was two types. There was professional contact tracing, citizen contact tracing. The other interesting thing about this diagram is we have a column called daily check-in, and there's a tiny little bit of text there that says not called symptom tracking. Daily check-in never made it through to the final service, but this just kind of shows the flux and flow of the ideas we were having at the time. What did we need? What didn't we need? So the professional facing contact tracing tools made it into production called simple tracing tools, and it was absolutely key to allowing Scotland to ease lockdown restrictions for the very first time around May 2020, if I remember correctly. And that was rolled out to all Scottish health boards and Public Health Scotland as well. And it was used for a short period of time before Public Health Scotland were able to produce the national contact tracing service. But really, this was a vehicle for learning. We produced it and it was used and it supported Scotland coming out of a lockdown. But really, we discovered and learned so much about what we can do in Scotland and the way we want to do it. The other part to contact tracing was citizen facing. So on the back of a notification service, after a wee while, citizens were invited then to do their own contact tracing. Again, this is a kind of just how many people who need notifying and need to contact trace can be taken out of manual systems. And again, as we heard earlier from Mark, there's digital exclusion going on here. Only so many people can do this, but a massive proportion of people did do this. So it eased the workload on public health teams. So again, this was used by the 11 health boards, also used a notification service. And the key figure last year was around about 60% of people were providing contacts through this form. And within 75% of those patients did so within 45 minutes. So this is a reasonably well-functioning contact tracing service. Final point is that we received backing from the Scottish Government quite early on. So this is a diagram that I made based on our early participatory design workshops, and it was published in the Scottish Government's first report on Test and Protect, or as it was called at the time, TTIS, so Test, Track, Isolate and Support. I think the marketing department got a hold of that one quite early on. But again, this shows symptom tracking, which was never came to be, and I'm sure it's a similar story in other countries. But we did a lot of things. We thought a lot of things would happen that never came to bear. But this is sort of showing you some of the working. Finally, I'd just like a call to arms. The DHI has been doing simulation participatory design for a long time, or for a number of years, I should say, and we've had some success with it. The Test and Protect services kind of validated some of that work for us. We were able to discover how things should work through participatory design very quickly. We were able to deliver a simulated service very quickly, and then
Sorry,
Pam?
That's about 8 minutes.
Okay, Doc, I'm just about to finish, Pam, thank you. And then we were able to deploy extremely quickly. We're still continuing to do that, and we have a number of services across Scotland using the same sort of approach. We offer sandboxes, so technical teams can come in and work with dummy data and work with what we call the DHI exchange, which allows you to exchange data in and out of NHS Scotland health boards. Yep, so if you've anything you'd like to get in touch with along those lines, then please do. That's all for me, Pam.
That's super, Jay. Thanks so much for that, and for doing it within the time frame. Perfect. Well, so I'll just hand over now to Anne Wales, who's the Programme Manager for Decision Support at DHI, and she'll talk about the COVID-19 work and decision support. Thanks, Anne.
Thank you very much. I'm just trying to share my screen now. Pam?
Yeah, we can see you.
Okay, well,
thanks.
Lovely, thank you. So thanks very much, everyone, for the opportunity to share with you some of our learning from developing decision support tools for COVID-19 over the past couple of years. So just to begin with a definition, decision support tools embed evidence, validated evidence within day-to-day systems and processes to enable health and care practitioners and citizens to do the right thing at the right time. Decision support has been described as a kind of sat-nav for the care journey because it guides practitioners and citizens through the journey of care, giving them guidance right from the stage of screening and assessment through to diagnosis, treatment and rehabilitation and follow-up. The National Decision Support Programme for Scotland's Health and Care, which I manage, has a mission to provide a Once for Scotland source of digital tools to empower professionals and citizens to make the best decisions possible about their health and care. And the Once for Scotland term or principle is really important because the programme is all about improving consistency and equity in use of evidence across the whole system. This is just a diagram of our Right Decision Service platform, which is how we deliver our decision support tools. So in sort of basic terms, the platform comprises tools for building web and mobile apps and populating them with content, also for building algorithms. So these are algorithms created by humans in the main, not machine learning algorithms in general. Where we're building algorithmic tools, we also need to obtain UKCA marking or CE marking, as it's called in Europe. The content and algorithms that we create are stored in a shared repository from where they're delivered through standalone mobile and web applications and also embedded in electronic health record systems. An important aspect of our platform is that as well as building tools centrally, we offer some of our builder tools out to health and social care staff, mainly to knowledge managers and clinical informaticians, so that they can use these tools to deliver decision support solutions that meet their needs within their organisations. So it's quite a distributed model. Using that platform, we've developed 3 kinds of decision support tool for COVID-19. Local guidelines and pathways being delivered as web and mobile apps. These are delivered through that distributed management approach with clinicians and knowledge managers locally, actually doing the publication and delivery of the apps. We've also delivered national tools incorporating guidelines and pathways for national use. In both of these cases, the key mechanisms or skills that are required are knowledge management skills to summarise, structure and organise the knowledge for easy access at point of care. And then the third group of tools are algorithmic tools that require CE marking or UKCA marking because they process individual patient data and issue recommendations for action. A few examples of each. I see the bottom of my slide has disappeared, so just quickly to show you, these are 3 local apps that were developed to deliver local access to COVID-19 guidance. This is the Lanarkshire app. This is the Greater Glasgow and Clyde app. And this one here was developed specifically for St John's Hospital in Lothian and was followed by a couple of other major sites in NHS Lothian. The St John's Hospital one, we were able to get up there literally within a couple of days of being asked to produce the app because we were able to mobilise that infrastructure really quickly, get their content up there and hand it over then for the clinicians locally to maintain and expand. The Glasgow and the Lanarkshire ones were entirely developed at local level using our national tools. A couple of examples now of national web and mobile apps for COVID. This one on the left is the web version of the long COVID app for healthcare professionals that delivers access to the national guidance produced by SIGN, that's our national guidelines body in Scotland, and by Scottish Government. So you can see it's all been structured and chunked up into quick, easy to access segments of information. This one on the right is I'm showing you the mobile version, though it's also delivered via the web. The right is the app for COVID assessment in primary care. And this app provides evidence about the likelihood that certain symptoms predict severe disease. Also at national level, we've delivered with the Scottish Intercollegiate Guidelines Network an app for patient decision support for long COVID. So this delivers access to patient information and resources to support self-management and engaging in discussion with their healthcare professionals. Particularly a popular feature is this symptom diary, where patients can record how their various long COVID symptoms change over time. They can save and print or email this to share with their healthcare professional to support shared decision making about the best course of action for them. And finally, the algorithmic tools, we developed two specifically for COVID. One was the algorithm for Restore 2, which is a tailored version of the news to early warning scoring system to detect deterioration. Restore 2 tailors news for use in care home settings with older people. We developed that algorithm, got the UKCA marking. Unfortunately, this one was never put into use, largely because the care record system providers we wanted to integrate with were concerned and uncertain about the implications of the UKCA marking and whether they would have any liability for any safety issues. What we did do successfully, though, was implement a standalone algorithmic tool, also UKCA marked, for calculating the 4AT scores for delirium assessment. This had actually been requested to sit alongside Restore 2 to help detect delirium in older patients or care home residents who had suspected COVID-19. So that one is out in live active use in hospital settings as well as in the community. In terms of impact, overall a good uptake. We've been able to track usage for a year now for the local and one of the national apps. All except Restore 2 are still in active use. They've been continuously updated since first delivery, so it hasn't been just a one-off. They've also really led to expansion into wider tool sets. So we now have a whole calculator suite, not just 4AT or Restore 2. Each of the boards now uses their mobile apps for delivery of a wider range of guidelines. And even Restore 2, which we didn't manage to get live at the time, is now attracting interest from a set of care homes in Midlothian. So nothing has been lost and a lot has been gained and grown. And you can see the positive feedback from the clinicians. Particularly at first, they were just so grateful to have a quick and easy place to go to get access to local guidance and to know that it was the most up to date for their organisation. Key learning points. Some I think are similar to what's gone before. The value of having that national infrastructure that we could mobilise nationally and locally. The benefits of having that devolved tool set so that local boards could use it to deliver and manage resources to meet their own needs. An important message, I think, is that certainly in decision support, this isn't only about the technology. The knowledge management skills and information management skills were really crucial, as were clinical ownership and leadership that really provided the impetus for all of these developments. The partnership with the national guidelines body was very valuable. It gave us that national reach that we couldn't have had just as a technology solution in isolation. An important take-home message was the need to raise awareness and address some of the fears of the unknown around UKCA marking and what its implications are in terms of liability. And finally, a really positive learning point was that all of these developments have led to something bigger and with wider reach and impact beyond the immediate COVID-19 crisis. So I think that kind of testifies really to the value of the infrastructure being able to expand beyond the immediate need.
And
Thank you.
That's 10 minutes. Are you just finishing off?
That's me finished.
Thanks. That's super. So thanks to for these 3 presentations. So we've got sort of 10 minutes for a bit of Q&A. So I'm just looking through here. So Anne, you had a question for Mark. I know there's been a bit of chat and sharing of documents, but just want to ask that now.
Yes, Mark, I was really interested to hear what you said about debunking some of the myths about older people not using digital tools. I come across that regularly in my own work. They'll never use these newfangled resources. So it'd just be good to know a bit more about the profile of the older people you found engaging with Near Me. And is it only the early adopters and enthusiasts, or is it actually more like the norm for a good proportion?
I think the results really challenged our assumptions, because it wasn't put and dried and what we thought it was going to be. It wasn't necessarily 70-year-olds versus 90-year-olds. We had very, very tech savvy people in their 90s and people in their 70s just weren't sure. And I suppose it is down to choice on the day, and I think that's something I want to try and reiterate. What's going to work for you today, no matter what age you are, no matter what health need you have. And it's again, if an older person thinks, do I have to get the bus, or do I have to find a relative to take to the hospital today? It would be great if I could do it from home, but I might need help, and that might be from a community connector. It could be from a relative, a grandchild, or a friend next door. So I think it's just having those person-centered questions with conversations with people around. If it's important to you, how can we make that happen?
Sure. Yes. Thank you. Thanks. That's a good message.
Thanks. Javier, you had a question for Mark. There. Hi there.
Hello. Good morning. Thanks for accommodation for all the speakers. All the good practices are quite interesting. I was wondering regarding the Mark presentation, always when you put this kind of solutions in the ground, there are several challenges, and one of them, of course, is how to take some measures about the success and what kind of variables you are able to take, you are able to measure in order to evaluate how it's going, the solution. And this is why I wanted to know if Mark has some results, some other information that could share with us in this sense.
Yes, it's a good question, and absolutely we want to make sure that what we're doing is actually having an impact. It's lovely to have these things to present, but so I suppose that the information, I've put some links into evaluations that have been carried out around Near Me. and the impact those have made. And I suppose the big game changer at the minute for us is group consultations. So many people who were having group sessions pre-COVID, a lot of that has stopped. So for example, diabetes management, weight management, mental health support. So that's what we're doing at the moment. They've just created a group platform within Near Me. So it would take about 3 to 4 people at a push. But now it'll take up to 30 with the plans for it to be 70. So that now opens up. So what we're just starting to support clinicians to run groups. So we're starting to get feedback and evaluations now from what's having a video group like for me, for my diabetes education, for my weight management, for my anxiety management. So again, so there's ongoing information gathering, and feedback from patients is key, really. And some prefer in person. So some services are running a blend of in-person groups and video, and they've had equal take-up of both, which is interesting. So I think that just shows that choice is still key around that. But yeah, there's if you have a look at the evaluations, you'll see the impact in terms of enabling services to still deliver something through the pandemic, but then keeping some of that now to say, right, how can we use it now? So we're broadening access for people.
Okay, thank you. That's great. So I think the next one was from me. So yeah, so Jay, I know we've had some on the chat, but for people who are not on the chat here, so if the project hadn't been delivered within the COVID emergency response, how long do you think a piece of work like that would take? So how much do you think COVID impacted on the piece of work that we're doing?
So it's an interesting question, Pam. I might hand over to Kate in a second if she can prepare an answer for this. But we published a paper in the European Medical Journal describing this work, and try as hard as I couldn't find any figures that supported how long it takes to implement a service in NHS Scotland, and I assume it's NHS England would do for comparison as well. So it's something I spent a wee while looking at, something that someone on the call might be able to help with. But I think that we know it can be described as very quick. But in terms of comparison, we just don't know. And the figures I was looking for were for implementation. But I think there's also an interesting point around how long does it take to surface the need for a new service? How long does it take to get agreement on the shape and type of that new service? So it's all kind of was smooshed into one for these 3 services. It all happened very quickly. Kate, have you anything to add to that?
I'm sorry, meeting and no, I would agree, very quick. But what I would also say is that some of the tools that we use, such as participatory design and some of the experience that DHI has of the background, running along the background of the governance and understanding of the necessary relationships that we needed for adoption, meant that there was an understanding across the organizations that will use this system. There's an understanding about the need, and there was a sort of rapid participatory design was very good at surfacing the needs, and Jay will talk about sort of more artistic linguistically, but it also meant that the clinicians who were all using it had consensus and buy-in in the system whenever it was ready to go.
Yeah, that's good.
One thing I think it's interesting to think about, Pam, just quickly, is what else could we tackle if we had a runway like COVID gave us? We did have a little chat about what could we do for diabetes or the big non-communicable diseases if we had this kind of will that existed at the start of COVID. Of course, at our first workshops, we were all literally terrified. It was there were discussions. It was all around negative notification in the first workshop, but we were asked, what if we needed to communicate mass numbers of positive? And it sounds silly now where we're sat, but at the time that, I remember one doctor clinician in the room just saying, we will never need to do that, or why would we need to do that? And there was genuine a bit of sort of a little bit of chaotic sort of thinking, so it's quite fun or quite difficult to remember back to those times. But yeah, it would be interesting to know what else we could do to long-lived challenges such as diabetes, mental health, whatever it might be, if we had the will and I presume funding to tackle it in the same way as we did, because these other conditions like diabetes and mental health are huge, you know, and looking back now, just as huge as COVID, you know, in some measures. So it'd be interesting to know what else we could tackle at such a quick pace.
No, that's really good, isn't it? Yeah, it's definitely another discussion to be had. So that's super. Thanks for that, and it's good to see you, Kate. I haven't seen you for a while. Nice to see you. Great. Okay. Right. Well, I think that's Scotland's best practice done. So I'm now going to move over to Galicia and introduce Benito Reguero and Alfonso Alonso Facharo from the Galician Health Service to talk about best practice.
Thank you, Pamela. Just a very brief introduction about Galicia and also our two speakers from Galicia. First of all, Galicia is a region, as you know, in the northwest of Spain. We have 2.7 million of inhabitants, and we face the problem of aging, where 22.5% of our population is over 65. However, we have three very positive things. The first is that we have one of the most powerful electronic health records in Europe, called Janus, and also we are leading in public procurement of innovation projects, and we were awarded by the European Innovation Council, EIC, last year. Also, in terms of research, we have 3 biomedical research institutes that helped us also to fight against the COVID-19. And the two speakers of Galicia will be the head of the microbiology service of the health area of Vigo, of the Galician Health Service, Sergas, and Benito Regueiro, who will present the pooling system of performing PCRs. And also the second speaker will be Alfonso Alonso, the Deputy Director of the Health Assistant Department of the Galician Health Service, Sergas, who will present our telemonitoring platform, Telea, that it was also used to fight against the COVID-19. So I guess, Benito, the floor is yours.
Good afternoon. My pleasure to participate in the meeting. And let me change to other very special, important setting in the pandemics, that is the diagnostic laboratory. So, of course, we have used several strategies to testing SARS-CoV-2 in our labs through the pandemic, mostly molecular techniques. And for instance, in our different facilities, we have been able, just here in Vigo, to perform close to 2 million PCRs. These strategies include one that is the matter of my intervention, that is the serial pooling testing. Classically, the pooling had been used as a system to save reagents and test large numbers of samples, compromising only a reasonable amount of the sensitivity of the say something that we will call the delta CT, that is the value that is the crucial value to detect the positives. The thing is that we have used the pooling in a different way. We have not based our system for pooling samples in the predictive positive value of the test, but in the negative one. So the idea is that instead of going to look conditions of high prevalence of the infection, what we have tried basically was to get areas free of viral transmission. And the 3 areas where we focus our capabilities were the healthcare workers, the care homes workers, and also the strategic industrial workers. Well, the first thing when we started working with our pooling system was the need of having a self-sample method for getting samples, and we have to change from nasopharyngeal swab, that, as you know, is the traditional and the initial way of collecting samples, to saliva. So we make this change, and for that purpose we have to design a new type of tube, only for 1 ml of sample, and we have to create a smartphone application just for the registration in our robotic truck. That would be the infrastructure that we will use for performing the pooling. So the system includes basically 3 initial robots for automation and pipetting that are able to check the reception of the samples, to decap the tubes, to measure the volumes and other critical points like viscosity, and to classify samples. Then, after these 3 initial brains of the system, we pass to the second, that is the pooling ability, that is made by one large start from Hamilton robot that is able to handle 960 tubes every time. So we have 3 of those, and we are able to perform a pooling that reduces the numbers of samples to, in the case of 960, to 48. And then finally we perform, let's say, a standard RT-PCR by using a system 3-start robots for purifying the nucleic acid, and then the 4 thermocycles for detecting the positives. As soon as we detect positives in the pools, we go back to the pre-analytics to select these positive samples, and then we go back to the RT-PCR for the pools resolution, and also we are able to apply smart pooling strategies, which basically means that we are able to put the positives in the negative pools entering in the system, and then only with 2 PCRs we are able to locate, like in a matrix, to locate the positive samples. So basically, because of the infrastructure, we use a pooling of 20 samples every time. After the end of this process, we get negatives and positive results. The negatives are immediately, because of the advantage of the smartphone application, are immediately communicated by SMS, and the positives, they go to the standard protocol that we have implemented as the system of our healthcare system. Well, of course, we have to compromise part of our sensitivity, and this compromise is what we call the delta CT. But what is important to have in mind is that every time that we perform one diagnostic procedure in different labs or using different reagents or systems, we have a bias that is presented in this publication that you see in the graph. In our case, what we have seen with large numbers, and you see the blue dots in the graph, is that the dispersion of values varies with the different CTs. So if you go to the negative value of the PCR, that is when you reach values close to 40, you have less dispersion than if you work with high values. What is important is that we have applied our pooling system basically to people that we don't want to enter in a specific area, like in a hospital or an industry. And the advantage is that basically we work with theoretically asymptomatic people. So what we expect is always to have values in the high values of the cities. In fact, we have to accept a compromise, and the compromise of false negative ratio is 2.9, and if we compare with individual testing is 0.3, which basically means that our whole compromise for the pooling systems used in this particular approach is less than 3.8 CTs. You have to think that if you compare right now the system that we are all using with antigen testing and with PCR, this difference is larger in the case of antigen, that ends probably in the 32 as the regulation starts. Limitations. The limitation is the prevalence. If the prevalence changes, you have to change the number of samples in the pool, and the infrastructure, that the geometry of your robotic tracks conditions your way of working. And the advantages. The advantages are that you save time and reagents. Here are the results we have from August 20 to February 22. So we have performed 900,000 tests. And allows to use new generation sequencing with the samples. And the advantage is that you can perform serial analysis, you can adjust the sensitivity of your test, adjusting the different robots. And one very important issue is that you can include more targets besides the coronavirus. So in fact, the last 2 months, we have been working with flu and with respiratory syncytial virus besides coronavirus. Thank you for your attention, and I would like to acknowledge the people that had working with me in this project. Thank you.
Thank you very much. So thank you. Alfonso Machado.
Hello, good afternoon. I'm going to share my presentation. First of all, I'm thankful for share this with you this journey of good practice in COVID. And sorry. Okay. Well, Telea is the short name for teleasistencia in Spanish, telecare in English. I'm going to explain you what is Telea for the Galician health system. It was very important in the pandemic for COVID. Well, Telea was created as a new chronic management model. We want to design telemonitoring for chronic pathologies in primary care. So we had a telemonitoring system that allow us to monitoring for chronic patients and to anticipate situation of worsening of the disease in our population. I want to say that Telea was highlighted as a good practice in primary care in the last year call for proposal for the European Commission. And this is the design of the Telea. Telea is a platform that is defined as a multi-patient, multi-professional, and multi-pathology telemonitoring system for chronic patients that links the patient home telemonitoring records with the patient's electronic medical record. In this way, the patient's home is connected in real time with the healthcare professionals responsible for the patients. Currently, Telea is available in all healthcare centers and hospitals in Galician of the Galician public health system. And this is the evolution of the patient recruitment during since the 2017. As you can see, the pandemic of COVID was very important for the development of for Telea, for the implementation of Telea. Today, we have 20,000 patients that are following in Telea COVID. And I want to explain to you how is the platform of Telea. The first one is the Telea patient display. As I said, Telea is a home telemonitoring system where the variable recording system works on calendar. The patient have in the calendar all the action and registers that they have to do. So the patient knows which day and at what time has to record the measurements taken. We can see here all the interventions that the patient has to perform during the week. And this is the view of the one day in Telea for the patient. It's important to note that one of the fundamental aspects of Telea is that the patient uses his own cell phone as a device. This has proven to be fundamental for the implementation of Telea because it allows accessibility and easy of use. This will need to be the case if the computers or tablet were used. Telea this is the Telea professional display, and Telea works for the professional as a system of control ranges that facilitate the homogenization of patients follow-up in all primary care centers. Thus, we have the zero control in the case of slight deviations from the established ranges, or a red control in the case of moderated deviations from the control ranges. As you can see in this slide, each patient is a chart that is defined with a color code in the control central unit, according with the degree of the control of the variables being followed. In this way, we can follow a significant number of patients on a single screen. 32 patients at the same time that we can follow up. We can select those who are worse and make the intervention made according to their condition. All the registration information is available for both the professional and the patient in the electronic medical record. For the patient, we can see this slide, all the records that the patient is introducing of in Telea that both can see, patient and professional. And these are the clinical variables that we can introduce in Telea, that the patient can introduce. We can register the blood pressure, we can register the weight, the blood glucose, the oxygen saturation, the steps, the heart rate, the body mass index, the temperature. In addition, Telea allows to the patient to complete clinical questionnaires that can be read immediately by the healthcare professional of reference. And finally, Telea ability to communicate between the patient and the professional. We thought this is very important, and Telea allows this to be done by emailing, by phone call, or by video consultation. Well, the application of Telea in the pandemic of COVID was necessary, and we had the tool. So we thought that we could to design a Telea profile in COVID with this inclusion criteria, the accessibility of technological resource, the knowledge of telemonitoring tools, or having a coverage who can give them the support, the diagnostic confirmation of COVID-19 infection without hospital admission criteria, and the adequate social and functional support that meets the home requirements established by the Ministry of Health from Spain. Well, these were the biometrics that patients with COVID have to register in Telea. They have to register the temperature 3 times per day, the oxygen saturation 3 times per day, the heart rate 2 times per day, and the blood pressure 2 times per day. And they have to register the questionnaires of Telea COVID profile that the professionals design. The first one is regarding with the respiratory pathology. The second is regarding with the door that the patient had the day before, and the last one is regarding with the mobility or other aspects. And these are the results that we have often published articles or in journal. The first one is the Telea satisfaction, the patient satisfaction. Regarding with the patient satisfaction, there are a total of 4,076 telematic surveys that we were sent to patients. We had a response rate of 80%, and 88% of respondents considered that follow-up by means of Telea was a good monitoring system for case of Telea COVID, and 92% considered that the follow-up by Telea provide a better quality of life than if they had been admitted to the hospital. The main patient satisfaction score was 4 out of a maximum score of 5, with 74% of respondents being had a higher or a very higher degree of satisfaction. This other article was a retrospective cohort study of all patients diagnosed with COVID-19 in Galicia between 26th of December of 22 and 15th of February of 21. The telemonitoring with Telea of patient was considered to be high risk in the area of Lugo, a health area in Galicia, and was evaluated compared to the other models in the remaining healthcare areas of Galicia. The number of cases in the Lugo area, called with a slum, was 4,384, and the number of the rest of Galicia was 42,669. The HIV healthcare comes with this monitoring model compared to those who from other regions of Galicia adjusted for age, where there were 1.3 admissions per 1,000 inhabitants in slum, whereas the ratio of the rest of Galicia was 1.8 per million inhabitants. Patient in monitoring in slum came to the hospital emergency department, less required hospitalization in lower numbers, and had shorter hospital stay. And the last slide I want to share with you is the figure that shows the monitoring periods for the program. The median time of monitoring was 11 days, and the probability of remaining in the program after 20 days was 90.2%. And that's all what I want to explain you. Thank you very much for your attention.
Thank you, Alfonso. That was really interesting. And just if anyone wants to put some queries in the Q&A, sorry, well, the chat, that would be great. I'll just go back through the chat. And I had just asked Benita about the other areas other than flu that you've been using the model for. Because I know you discussed it, I didn't quite catch it, so it's just to talk about that.
Well, the idea is that eventually changing the targets or changing the system that you use in the final step of the process, you can do practically anything, providing that it works with the right sample. So you can use the system as a general method if you are able, of course, to compromise certain amount of the sensitivity. The idea is that if you think that normally in a standard lab you are able to produce every day 4,000 samples, or you can work with 4,000 samples, think that using this other approach we have been able to work with 15,000.
Super. Thank you very much. Thanks.
You're welcome.
I don't see another question here, but Alfonso, I was just going to ask you, so obviously your patient satisfaction seemed to be very high. Were there any slight challenges in engaging the ageing population in that model practically day to day in monitoring them?
Yes, the satisfaction is high in this study and others that we made. One of the questions that we had was the digital divide of the older people. Galicia is an community with older people, but we had no problems with them. They know how to use a mobile phone. They know the pandemic of COVID was good for the evolution of the new technologies, and we have facilities in this aspect, and that people that couldn't use the platform come with their families, the son, the daughter that could you to help them.
Yeah, so just got family support with that. That's great. Thank you very much. So two really interesting presentations. Oh, there's some hands up. Anne?
Yes, thank you very much for both of those presentations. I just wondered, Alfonso, you talked about the thresholds that would give rise to either your yellow sign that symptoms or vital signs were slightly out of control, and then the red flag that signs are very much out of control. I just wondered how you set the thresholds that give rise to those that act as triggers. Is that done on a person-by-person basis? Because I know particularly in older people, what's normal can vary greatly from one person to another. So I wondered if those thresholds were set on a person-by-person basis, or do you use substandard average thresholds?
You asked me is we respond to person by person, to the patients.
Yes, I was just wondering about the thresholds. So, for example, if you're measuring heart rate, what's normal for one elderly person may be different from what's normal, for a younger population. So I just wonder, how do you determine what's normal in setting your thresholds that trigger the messages that signs are out of control?
The normal range is defined by the professionals, and they say and they define which is the normal range in every variables. And if one patient have yellow alert, then we have the nurse who's contact with the patient all the days except Saturday and Sunday. All the days the professionals, nurse or doctors, see the CCU, and then if there is one patient that have an alert, yellow or red, they call to the patient and they see what's the problem, how to resolve. They can't resolve with the telephone, or they can't resolve with a video consulta or another way, no? But it's individual, the response that we give. We saw the CCU, the control unit, but we resolved one by one.
Very much, thanks.
Thank you.
Thank you. So thanks again to Benito and Alfonso. That's super. And I'm just going to hand over now to the Basque region. We have Alicia Rodriguez Gascon and Susana Garcia Gutierrez from Osakidetza Basque Health Service. So, hi there.
Excuse me, Pamela. So this is Xavier from the Basque Country. I would like to introduce Alicia and Susana. The first one, because both are researchers that are part of the Basque Public Health System groups. They are collaborating. They are taking part in the Health Research Institute associated with some of the main hospitals in the Basque Country. So the first speaker who is also a researcher is Alicia Rodriguez Gascon, who is a PhD in pharmacy and is a full professor of the Faculty of the Pharmacy of the University of the Basque Country. She also is part of the microbiology, infectious disease, and antimicrobials of gene therapy groups, which is associated to the Bioraba Health Research Institute. And in the coming seconds, I guess that she is going to talk about a good practice related with the bacterial and fungal superinfections associated with the patient that suffers COVID-19. So I don't want to to use more time, so I leave you the floor, Alicia.
Thank you very much. I will share my presentation. So the title of our work is multi-drug resistant bacterial and fungal superinfections in SARS-CoV-2 critically ill patients, pharmacokinetic and pharmacodynamic analysis to optimize antibiotic treatment. So in our hospital, the Hospital Universitario Araba in the city of Vitoria, there is a research team composed by the microbiology service, the intensive care unit, the hospital pharmacy, and in this group also there is a collaboration with a research group, the Faculty of Pharmacy, the pharmacokinetic, nanotechnology, and gene therapy group. And the main objective of our group is to optimize the treatment with antibiotics, mainly in critically ill patients. So with the COVID pandemics, we have tried to apply our methodology for the treatment of these patients with antibiotics. So it is known that the SARS-CoV-2 virus predisposes to the acquisition of multi-drug resistant bacterial infections in patients at the intensive care units, and therefore COVID-19 may have a negative impact on antimicrobial resistance. In this context, it's clear that the optimization of antimicrobial therapy is essential to reduce the resistance of bacteria to antibiotics. Taking into these considerations the objectives, our work was to evaluate the prevalence of co-infections and secondary infections in COVID-19 patients and of the intensive care unit of our hospital, also to determine the phenotypes of resistance to antibiotics, as well as the resistance mechanisms and the genetic diversity of clinical isolates of these patients. And finally, to develop a tool to optimize the antimicrobial treatment of co-infections and secondary infections of these patients in the ICU. As a first step, we evaluated the prevalence of co-infections and secondary infections from March to June 2020, the first wave. So in this period, 92 patients were admitted to the intensive care unit, and 26% of the patients presented co-infection. That means the infection was present at admission or in the first 24 hours of the admission in the ICU. And 47% of patients presented secondary infection. The more frequent sample type was respiratory, followed by urinary, blood, and catheter tips. The most frequent bacteria isolated from the patients were Staphylococcus coagulase negative, Enterococcus fecalis, Enterococcus phaeacium, Pseudomonas aeruginosa, Escherichia coli, and Candida. On the other hand, whole genome sequencing is a very useful tool to detect and to know the frequency of bacterial with resistance to antibiotics. We have applied this methodology to evaluate the profile of resistance of the isolates of the ICU unit. As an example, we evaluated 69 isolates of Pseudomonas aeruginosa from April 2020 to June 2021. We detected only 4 susceptible isolates, 29 isolates with moderate resistance to antibiotics, and 36 isolates with multi-drug resistance. Among these, the most frequent clone was 175 with a frequency higher than 30%. This clone is a high-risk clone with resistance to many antibiotics, including penicillins, cephalosporins, monobactams, carbapenems, aminoglycosides, and quinolones. This methodology is very important, first to detect the presence of resistant isolates and also to prevent the dissemination of these clones in the hospital. We have also evaluated the resistant phenotypes of the isolates. For instance, for Klebsiella pneumoniae, we find a good correlation between the phenotype, the resistance to many antibiotics, to the presence in the isolates of resistance genes. We have also applied the pharmacokinetic and pharmacodynamic analysis to optimize the therapy with antibiotics. In this sense, it's clear that the success of the antibiotic treatment is not only dependent of the susceptibility profile, but also the pharmacokinetic profile, that is the exposure of the antibiotics. That means it's very important to control the concentrations of antibiotics in blood of the patients, which are dependent of the regimen dose. By combination of this information and by applying mathematical modeling and Monte Carlo simulation techniques, the pharmacokinetic and pharmacodynamic analysis allow us to estimate efficacy indexes that are indicative of the probability of treatment success. So we applied this methodology to optimize the treatment with antibiotics in terms of selecting the best antimicrobial agent, and also it is very important to select the best dose regimen, and even to select the way of administration, for instance, optimizing the length of perfusion. Example, we have applied the pharmacokinetic and pharmacodynamic analysis to evaluate the adequacy of voriconazole for the treatment of infections due to Aspergillus. So in a first step, we compare the MIC levels of the Aspergillus isolates before and after the COVID. During the period of the study, we didn't detect changes in the susceptibility profile of Aspergillus to voriconazole. Then, taking into account the susceptibility profile of Aspergillus in our hospital and also the pharmacokinetic of voriconazole in critically ill patients, we estimate the probability of the treatment success. So, voriconazole provide a very high probability of success if the MIC of the isolate is lower or equal to 0.125 milligram per liter. The probability is higher than 95%. And for empiric treatment, the probability of success is also very high, from 82%. It depends of the Aspergillus. It's close to 100% if the infection is due to Aspergillus nigricans, 87% for Aspergillus fumigatus. So just to finish, I would like to point out the importance to work in collaboration. In this case, the microbiology service who study the susceptibility profile of the isolates. Very important, the whole genome sequencing studies, the resistance trends over time. Of course, very important, the contribution of the intensive care unit who take care of the patient and to identify risk factors. The hospital pharmacy who evaluate the consumption of antibiotics over time, and it's very important to relate the use of antibiotics with the resistant trends. And the pharmacokinetic group who, in cooperation with the rest of the groups of the hospital, to carry out pharmacokinetic studies and to apply the pharmacokinetic and pharmacodynamic analysis to optimize antibiotic therapy. I would like to thank you very much, the Fundación Vital, the University of the Basque Country, and the Institute of Research in Health. And thank you very much for your attention.
Thank you. That's very interesting. So we'll pass over to Susanna. Sorry, Carby.
Hello, everyone, again. Now the next speaker from the Basque Country region is Susana Garcia. Susana Garcia is a clinical epidemiologist that works in the Galdacao Hospital. Galdacao is also a hospital, which is a tertiary hospital in the Basque Country system. Her line of research is predictive modeling in acute condition and the composition of the chronic disease, and her research team's goal was to characterize prognosis of hospitalized COVID-19 patients in order to provide the physician with a clinical decision support the system. So this is going to present you how they use this information for featuring the patient. So, Susana, glad to see you. The floor is yours.
Okay. Do you see my screen? Is it? Yes?
Yeah, perfectly.
Okay, bye. But thank you, everyone. Nice to be here. Thank you very much for your consideration. Now I'm going to present project entitled Prediction of Clinical Deterioration in Patients Admitted Due to COVID-19. During these minutes, I will justify the project, tell you about basic aspects about the methodology, and I will present our results and corresponding conclusions. Okay. Well, in March 2020, a tsunami of patients arrived to our emergency department, most of them with symptoms consistent with infection by SARS-CoV-2. In Spato, we knew that this virus existed and it was very near of us. Almost neither of us knew that COVID-19 was so different to other viruses. One of the most amazing characteristics was not patients did not feel shortness of breath until very advanced disease. Okay. Siddiqui et al. In March of 2020 told us about there are two distinct but overlapping pathology subsets. The first triggered by the virus and the second by the host response. Okay, then being that one of the main complications of COVID-19 was acute respiratory distress syndrome, we saw that clinical manifestations were relatively mild in almost all patients, specifically in early stages of disease. These patients might not complain of dyspnea and have no significant increase in respiratory rate or the respiratory distress. Okay, and then the challenge for managers and physicians in this context was to identify patients at risk of developing severe forms of the disease with the aim of allocating resources and adequate treatments. Almost all the literature were concerned about the probability of being admitted in the intensive care unit or death. Gupta et al. In 2020, I think that was soon in the pandemic, developed a ISARIC forced deterioration model. Okay, the main outcome was to detect those patients in with a 6 points in the WHO clinical progression scale, that is hospitalized and receiving oxygen or mechanical ventilation. Okay. But we were fairly convinced that in the first stages of the pandemic, not all the patients had the same opportunity to be ventilated. So aim was to detect those with 5 level, is there? 5 level on the WHO clinical progression scale. We wanted to detect those patients who were ventilated with a less a standard high flow oxygen face mask with a reservoir bag. Because the decision of escalation was not based just in only in clinical aspects. It was also based in management of resources in pandemic, and to not considering them could be traduced in an infraestimation of the risk of severe disease. Okay, then our objectives was to identify predictive variables of clinical deterioration, including high flow oxygen face mask, okay, and or admission to a critical care unit or death during hospitalization, and combine the above variables into risk scales. With design, we developed a prospective cohort study of patients admitted in 3 participant centers. We collected data from electronic health records, from baseline, that is sociodemographics, comorbidities, basal treatments. Later, we collected information about vital signs, treatment, and lab tests in emergency department and during hospitalization. And at the end, we collect 2 ventilatory support need, intensive care unit transfer, or in hospital death. Okay. Our sample then was divided in development and internal validation dataset. We downloaded patient level data from the period March 1 to April 30 in 2020. And validation dataset. Furthermore, a prospective validation was collected from May 1 to October 7 of 2020. Then, from the analysis, 1,568 patients were included. Here it is. 23% of them were deteriorated, and in external validation dataset from 956 patients, 19% of them were deteriorated. Okay, in this slide, I want to show you the characteristics of the patients included in derivation and validation cohorts. Okay, there were differences between cohorts in sex and age. Patients in the external validation were younger. There were no differences in comorbidities between cohorts except for dementia. There were some more patients taking chronic medications in the external validation. These data are not sound. But regarding to vital signs on arrival, no differences were detected except for temperature and oxygen saturation being lower and higher respectively in the validation sample than in the development sample. We also found differences in several lab results, specifically inflammation markers being lower in the development sample. Based on this information, we combined the aforementioned variables for a machine learning analysis using the catbot algorithm. We also use logistic regression for further model evaluation and comparison. Different models of Tittan in the development set were applied in the validation set, and the model who achieved the best outlook was selected as the best one. Okay. In order to make results about the interpretability of the prediction model, we use a Shapley additive explanations approach. Okay, this is a unified approach for explaining the outcome of any machine learning models. Sub-values evaluate the importance of the output resulting from the inclusion of feature A for all combinations of features other than A. That is, features being shown in blue, okay, these ones, indicates that their values are less likely to predict the outcome, while values in those shown in red are more likely to predict the outcome. For example, patients who reach the endpoint of obtaining the lowest values of partial oxygen saturation, okay, present better prognosis, okay, that those with high patients who reach the endpoint of obtaining the lowest values for partial pressure of oxygen, platelets, and lymphocytes, and eosinophils, and the highest values of CRP, H, procalcitonin, urea, LDH, creatinine kinase, were more likely to present bad outcomes. Okay. In the case of baseline treatments, which were dichotomous variables, those who took neuroleptics, antiacids, and or diuretics, they are here, okay, were more likely to deteriorate than those who didn't. Okay. Well, based on the distribution of the outcome about across the predicted probability in the development and internal validation dataset, we created 5 risk groups which were tested in external validation dataset. We calculated the performance parameters for each risk group. Okay. Conclusions. We have developed and validated a clinical prediction model, including routinely available information recorded in the electronic health records. This model includes chronic treatments prescribed at baseline, lab results, and vital signs on arrival at hospital, and predicts poor course in patients with COVID-19 before transfer to an intensive care unit. Therefore, it is expected that it could improve triage systems, allowing earlier identification of patients who are likely to need intensive ventilatory support. These decision support systems must be flexible and had to be continuously updated to detect variations in patients' characteristics that make them differently vulnerable. We present a machine learning-based prediction model with excellent performance properties to be implemented in electronic health records. Our main goal was to predict progression to a score of 5 or higher in the WHO clinical progression scale, prior to patients requiring mechanical ventilation. Future steps are to externally validate the model in other settings and in a cohort from a different time period, and to apply the algorithm in clinical practice. Thank you very much for your attention.
Thank you so much. That was super. So we've got a bit of time now for Q&A. If anyone wants to put their hand up or drop something in the chat. I was just going to ask Alethea. So I'm not. Okay, hi. I'm not a clinician, so forgive me if I haven't understood some of the science. But how long did it take you to do the study and then start to impact on the medication for patients? How did it work with the COVID timeline? Were you doing it in parallel, or how did that work?
Normally, we were together in research with this methodology. So for us, it was a challenge to apply this for COVID patients. So it's clear that it's very important to know the local microorganisms in the hospital, in the area, and once you have developed the pharmacokinetic model, it's easier to apply. It's not, to apply this methodology is quicker if you know the local microorganisms in your patients.
Okay.
I don't know if I have answered more or less your question.
Yes. No, I see what you're saying, and I didn't catch that because I'm not very scientific. So thank you very much. Thank you. Are there any other questions? No, it's maybe everyone's ready for, let me see, a coffee, or let's see. Yeah, so I think we'd scheduled to 3:40. Yeah, a bit of a coffee break now. So if everybody wants to do that, and then we'll come back at 2 o'clock, and we'll hear the presentations from Germany then. And thank you very much to all the speakers so far. It's great. Okay, so I'll see you at 2 o'clock, everybody. Hi there. Is Olaf on the call?
Yes, absolutely.
Hi. So yes, I just want to introduce Dr. Olaf Müller, and Olaf, I'll let you introduce your team from Germany and pass over you to present. Perfect. Thank you so much.
Hi guys, Olaf Müller is my name. I'm from Caros Concilium Saxony, and in the Tittan context, responsible for the activities of Healthy Saxony, which is a regional health and care cluster organization. Thanks so much for the organizers. It's pretty much a lovely day. I hope very much that my Wi-Fi is working, because I am not at home or in the office. I'm actually in my vacation time, which proves to be kind of complicated because I now have 2 COVID-19 positive girls to care for and a presentation. So yeah, it's gonna be fun. Nevertheless, we're doing this because I could not have Stella do all 3 presentations. She would basically kill me. I'm pleased and honored to introduce Stella Bauer, which she is also responsible for the Tittan activities with Healthy Saxony, and she will have one of the 3 presentations, but it's my pleasure or duty to do the first and the last. So if that's okay with you, I would basically go.
Great, thanks.
Stella will share the slides.
Yes, one moment.
Okay, so in the meantime, I can briefly introduce what we are going to talk about. We decided.
Queen?
Yeah, perfect.
Working? Okay.
Okay.
Perfect.
We decided to go for 3 good practices with regard to healthcare delivery pathways, because this is the one thing where most of the activities with regard to COVID-19 took place in Saxony in particular and in Germany in general. And to understand the degree of innovation of these delivery pathways, I would give you at least 2 or 3 sentences with regard to the usual German health and care system, which is kind of rigid, kind of 19th century, very Bismarckian, complicated and pretty resistant to change. With a high degree of so-called self-government, meaning that the health and care actors are used and meant to govern themselves. So hospitals organize the hospital business, GPs and specialists organize their GPs and specialists questions, and there are only some kind of governing associations, but all of them are separated from immediate government influence, which is the major change. So it's, I wouldn't say it's worse than other systems, it's just different, but it has a definite disadvantage with regard to the speed of innovation to market. So in that particular aspect, we are simply too slow. So that being said, COVID changed a couple of things pretty interestingly. One of these is our first good practice that I will talk about. Within Saxony, Stella, give me a click, please. Okay, and another one. Thanks. Within Saxony, as you can see here, there's basically 2 major towns, Dresden and Leipzig, both 500,000 each, and a third larger town, Chemnitz, of about 250,000 inhabitants. All these 3 major towns have we call it maximum care hospital. Dresden and Leipzig, a university hospital, and Chemnitz, a municipal hospital. They are more or less comparable in size, about 1,200 beds and some treatment numbers for outpatients as well. Usually there's kind of competition between all 3, even though they're kind of 75 to 100 kilometers apart, but still they're too close to be completely separated. So there's usually competition. So within COVID, things changed dramatically. Pretty quickly, a kind of internal informal cluster organization was set up, where each of these 3 major hospitals took the lead and a governing and how to say that, kind of a leading role in organizing all other hospitals in their specific area. So from Dresden to the east, Leipzig northwest, and Chemnitz southwest, the major hospitals were basically charged with organizing COVID in hospitals for all the others. So there was coordination, there was decision making with regard to where to put the patients, there was decision making with regard to are there enough respiratory units on the ICUs, do we need transfers, etc., etc. So there, from scratch, within a few days, there was a hierarchical structure introduced into a self-governing German system. This was major. First major change to the system since, I don't know, 18 something. So to understand this from a, for instance, NHS system where there's government influence, this is really new. It worked smoothly. This was the interesting thing. There was no complaining, no, this is too much control for me. So this was actually working smoothly, and guaranteed that there was no kind of overtaxation of the system in specific smaller hospitals within the rural areas of Saxony. So it worked kind of well. There were some critical levels introduced from where a second innovation, which Stella will present afterwards, kicked in. It's kind of a national reallocation scheme, but Stella will talk about that. And from these critical levels within Saxony, then the next level of we need help kicked in. These levels were both introduced to normal care and ICUs with different thresholds with regard to the capacity that is actually in place. Okay, one click, please. Usually you would see a number of dashboard graphics where you could see the specific leveling within these clusters. Kind of, there you go. Which were basically filled in, I think, 3 times a day, and then exchanged between all the players, including government authorities, just to keep them informed. It's not that they couldn't change much, aside from informing the federal government with regard to Saxony's fine or Saxony's not fine, but still to keep them in the loop. There were daily conferences within the cluster, within the hospitals in the cluster, and including government authorities, the Deutsches Rotes Kreuz, the German Red Cross, and other facilitators, in order to keep the ship afloat, which in terms of Saxony was kind of tricky, especially during the Delta strain, where the Saxon health and care system was basically completely overrun. And I think this is one of the days within full Delta, so it was basically completely full, deep in the reds. And nowadays it's much easier. I haven't managed to collect a more recent slide from these dashboards, because now it's pretty turned down again, so it's kind of smooth and okay. Hospitals are returning to their usual way of communicating, and the interesting thing stays, and no one wanted to answer it: is this cluster organization going to survive in the post-COVID time? This is gonna be very interesting. Okay, thanks. Next, Stella. Okay, yeah. So I told you when thresholds were reached, a national scheme kicks in, and this is the one that Stella will talk about.
Yes. Thank you very much. Can you hear me?
Yep.
Okay, fine. So, as Olaf already told, I want to present the National COVID-19 Patient Reallocation Scheme to you. It is also called the cloverleaf concept. Yes, first of all, what is the cloverleaf concept? It was developed in spring 2020, in context of the corona pandemic in cooperation between the federal and state governments. And the scheme coordinates and regulates the nationwide reallocation of COVID-19 patients who are requiring intensive care. Since the COVID-19 incidences increased exponentially, and so did the number of severely ill patients. Since the capacities in the area of inpatient care of intensive care patients are limited and cannot be increased as needed due to required material or specific qualification of the staff, it became necessary to develop a system that balances regional overloads of intensive care units and prevents triage. So the cloverleaf concept is used when the intensive care units in certain hospitals or different clusters in Germany are overloaded, and coordinates the distribution of affected patients to other cities or even other states. So in the cloverleaf scheme, Germany was divided in 5 different parts, like a 5-leaf clover. You can see that it is divided in the east, south, southwest, west, and north. And there are different stakeholders at the operational and strategic management. First of all, the operational management. One leaf includes 1 to 5 federal states. For us, regional relevant were the East Leaf. This consists of Thuringia, Saxony, Saxony-Anhalt, Brandenburg, and Berlin. You can see this in the map in the light green part. And within the leaf, one state is nominated as the single point of contact, short SPOC. And those SPOCs function as regional coordinating authorities, together with GMLZ and a specialist group of the RKI. GMLZ is is a special part of the Federal Ministry of the Interior and Community, which deals with civil protection and disaster assistance. And the specialist group of the RKI is a division of intensive care medicine, infectious diseases, and emergency medicine. So the SPOCs are responsible for the implementation of the concept. And yes, in order to this purpose, regular conferences are held. And the strategic management is responsible for the evaluation of the national situation. And it consists of representatives of the SPOCs and of representatives of different ministries of Germany. And like in the operational management, here I also hold these regular conferences with temporal connection to the meetings of the operational management board. So in the cloverleaf scheme, there are 3 levels, like a traffic light scheme. The first level is the green level. This describes the normal situation in hospitals. That means that patients are transferred to other clinics if capacities have been exceeded. Yes, as a result of increasing hospital occupancy, the planning level yellow is reached. And here the states start to monitor the occupancy to avoid local or regional hospital overcrowding. And if there are signs of an overload situation, the planning level red is reached. And if an overload situation occurs in a cloverleaf, the operational management board is alerted by the SPOC, and the patients can be transferred regionally or nationally. So if the state or if the states within one leaf still have capacity, the patients are transferred regionally, so within the leaf to another leaf state. And but if the capacities in one leaf are exceeded, the patients are transferred nationally. That means into another clover leaf. The SPOC describes the patients to be transferred according to an agreed protocol, which is also the basis for the requested SPOC to search for a clinic. And the strategic reallocation take place over longer distances, approximately 400 to 1,000 kilometers, or over a longer period of time, approximately 6 to 12 hours. That means that the patient's condition must be able to withstand this higher burden. And because of that, which patients got transferred is decided on the basis of various criteria. These include, for example, health and physical criteria. And at least the SPOC of the East Cloverleaf activated the Cloverleaf concept in December 2020. There the patients got transferred regionally, so within the East leaf. And for the first time, or patients got transferred nationally for the first time in November 2021, when the SPOCs of the South and the East Cloverleaf activated the Cloverleaf concept. Yes, and since then, the strategic transfers of greater distances for capacity balancing took place throughout Germany. Thank you very much. That's all from my side.
Okay, thank you, Stella. Interestingly, the transfers from Dresden happened to Bremen, which later on received the highest incidence rates in Germany.
Yes.
But that's a typical Saxon joke, because Saxony for quite some time had the highest incidence rates in Germany. Now we're pretty even. Okay, yeah. Third good practice deals with something more positive, how we increased the vaccination rates within Saxony. Interestingly, but nobody exactly knows why, Saxony has the lowest vaccination rate throughout Germany and keeps its place. So there's no changes, more or less. All federal states increase slowly in rate, but still Saxony is lagging way behind. Some say it's because of the forest and wolf structure, so there's lots of rural areas, but that can't be the only reason, because Bavaria also has forest and wolves and is better than Saxony with regard to the vaccination rate. It causes problems basically because we see a strong reluctance within the population not to get vaccinated for several reasons, most of which are more emotional than logical in nature. So you can basically forget of changing anything fundamental with this. So in order to also important is that this reluctance does not only refer to the general population, but is also found within health and care actors. So there's still a 2-digit percentage of non-vaccinated care personnel in the large hospitals. Huge problem, obviously. By now, there's a mandatory vaccination in health and care actors, but still, some of the carers we know basically deal with this in a let's see what happens kind of way, and still don't get vaccinated. Okay, so to deal with that, we started hospital-based vaccination campaigns very early, out of 2 reasons. One is that there was a large number of physicians that were actually able and willing to vaccinate others. Secondly, we had a kind of well-working flow of vaccine, which in the early days was pretty hard to come by. And it happened that even with a kind of good distribution system and electronic appointment systems for the vaccination centers, at the end of the day, sometimes there was the vaccine left over. So what happened? The larger hospitals created informal structures to collect leftover vaccine and use it by noon next day. So nothing was spilled, nothing was wasted, and it was pretty quick, pretty agile structures to get the vaccine, firstly, of course, to the health and care personnel within this specific hospital, but later on to relatives, suppliers, networking partners, etc. So it basically spread from the inside out, and more or less went without much official ado, which was kind of un-German approach. Extremely efficient, and this is the interesting part, completely organized bottom up. So we had you could call it vaccination flash mobs, more or less. A specific clinic decided, okay, this Friday 1 p.m. there's a vaccination campaign, come get your vaccine. And they were so smoothly organized that basically within 5 minutes, the whole waiting area, you need to wait 15 minutes in order to see if anything happens. The whole waiting area were crowded with hundreds of people who all got vaccinated in the first couple of minutes. So this was extremely efficient and went pretty well. Nowadays, we don't have the problem anymore because there's enough vaccine and a lack of people who want the stuff. But still, in the early days, this was really important to increase the vaccination rates at the point of care as fast as possible. Still, the downside of the whole thing is that it doesn't change much with regard to the general population, because more or less all of the hospitals had their own campaigns by now. They're the municipal vaccination centers, the Saxon vaccination centers, some private centers, etc., etc. If the GPs are vaccinating by now, it's more a lack of general populace who wants to get vaccinated. But still, again, for a rather rigid system, this was a very agile approach, not to waste a single bottle of vaccine, which was in the early days. Even now, it's a very valuable stuff in order to keep the population safe. Okay, this was basically all from us.
Super.
Any questions so far?
So any questions? Anyone wants to put their hand up, or any more questions on the chat? No, but I'll just go through my question. We'll have and maybe. So I know that you have responded to this, but when you were talking about the clusters being in competition prior to COVID, I was asking, do you mean competition to attract patients and therefore payments or insurance payments? And did that mean that patients living closer to cluster borders would have had a choice of where they wanted to go for their care?
No, it's actually more that there was no cluster or any other cluster-like organization at all. So it's basically everybody for himself. And competition meant more like competition for specific fields of care. So the system in general works with it's kind of prepaid. It's not actually tax paid, but kind of. And so there's no absolute competition, but there's a pretty strong competition at the highest level of high-tech medicine, like for instance transplantations, bariatric surgery, neurosurgery. So the really interesting stuff, which is usually only done within university hospitals. And there's a strong competition because the range between competing university hospitals can't be large enough. For instance, the proton therapy for cancer patients, there's a number of 4 clinics nationally who are doing this. So there's a strong competition across whole Germany. Dresden and Leipzig are competing in terms of transplantation surgery. Dresden and Chemnitz are more, I would say, close friends. It's like historically based, but Dresden and Leipzig, there's strong competition. But in this situation, everything stopped and everybody was working together smoothly. It actually was amazing. I hope very much that some of this collaboration culture survives, because this would actually advance the whole system.
Yeah, that's great. Ryan Cooper, would you like to?
Hi, good afternoon. Yeah, just following up on what Olaf's saying there, I think I was going to ask if there'd been some sort of quality assurance collaboration, sharing that good practice, sharing incidents, sharing more than just passing things around or patients back and forward. Yeah, that quality infrastructure, was that embedded throughout that joining up?
There was a quality-based, or let's say more medical collaboration in the field of how to deal with that, how to treat patients with respirational problems on the ICUs, etc., how to use the ECMOs. Some of the deep details are still kept within the academic group, I would say, but there's a strong collaboration in this field, and this collaboration is not restricted to Saxony, but it's done on a federal level. So basically, firstly, in the group of the university hospitals, there's a very strong collaboration in order to get to know the disease and how to deal with it. This was pretty fast, actually, because we have seen guidelines for dealing with ECMO patients on the ICUs pretty quickly, actually. Much faster than it would usually have happened, and pretty sure that this collaboration will definitely survive afterwards. The administrational clustering stuff might go down the river, but the academic collaboration will definitely survive. There are national networks already founded where there haven't been any such networks before, and they will definitely continue.
Excellent, thank you.
Pleasure.
Any other questions? Can I ask another one?
Of course.
Yeah, so what sort of areas of care then do you think this cloverleaf model will be replicated for quite swiftly after COVID? Beyond, I know you've talked about the agile approach to the vaccinations, and are there any other key areas you think?
I would guess that the cloverleaf works pretty well in special situations. So like mass incidents of any kind. Usually the German system tries to keep patients close to their home as far as humanly possible. So this was kind of a new situation. Transferring patients from Dresden to Bremen is kind of one time across the whole country. So this is very untypical. We usually don't do that. But in this case, it was just necessary because there just wasn't any bed wherever to to be found. So I think this system will hopefully we don't need it that soon, but if we do, we know how to do it. So this will in other cases of national diseases, disasters, whatever, hopefully they don't come, this system will probably be reactivated because it proved that it works.
No, it's great. It's another example of what you can do quickly when the pressure is there. So,
yeah, absolutely.
So thank you so much, Olaf and Stella. That was super. Are there any last questions? No. Okay. So we will move on to Italy. And I'd like to welcome Paola Bello from the Regional Foundation for Biomedical Research. Hi, Paola.
Hi, good afternoon, everyone. Hi, can you hear me well? Yes, okay.
Yeah.
So, good afternoon, everyone. Thank you very much for the organization of this meeting. All the practices presented so far are extremely interesting. So today, my colleague Marcello D'Amico and we are going to present some practices from Lombardy region. As you know, Lombardy region was one of the first areas in Western Europe to be hit by COVID-19. So today we will focus on 3 good practices that actually represent 3 sets of good practices from 3 different hospitals. The first 2 refer to good practices implemented by a hospital facing the crisis, facing the moment of the highest emergency. The third one will refer to the post-first wave of the pandemic, and we will explain how an hospital was able to recover and to in a sense, go back to all the services that had to be postponed because of the pandemic. So I will start with the first good practice, COVID-19 pandemic experience from a frontline hospital. In particular, we're going to discuss what the hospital of Bergamo, Papa Giovanni XXIII, has put in place. Okay, next slide, please. So the hospital Papa Giovanni XXIII is one of the biggest hospitals in Lombardy. As some of you may have heard, it was, well, not only the region most hit by COVID in Italy, but one of the cities that had to deal with the most severe consequences of COVID. So the hospital of Bergamo found itself in a position to face the emergency and to find new procedures to implement in the shortest possible time. So the medical team and the management team at the hospital decided to adopt new procedures. Among them, they established very quickly a crisis unit. It was composed by management staff, but also representatives of the medical staff and nursing staff. The aim of the crisis unit was to meet every day, to plan day by day the activities according to the emergencies of the day. The second was the immediate introduction of a number of protocols and new rules to access the hospitals, creating different paths and differentiating patients, those affected or presumably affected by COVID, and other patients. Then it was quite immediate, the knowledge that more staff was needed. So in this case, the region, so Lombardy region, could intervene. The region launched a number of it opened a number of job opportunities for medical staff and nursing staff. So the hospital of Bergamo, as well as other hospitals, could receive more staff to work on the COVID patients. And then there was an extended use of a platform for telemedicine. In particular, they have a platform called Phoenix. It was something that was already in place before the emergency, but during the emergency, its use has been has increased enormously. For instance, through this system, it was possible for doctors to send prescriptions to their patients without the need for patients to go physically to the hospital. So the use was absolutely promoted. Okay, next slides, please. So, as said before, the area of Bergamo was one of the most hit by SARS-CoV 2019. So it was quite clear that to face the increasing number of patients, the medical staff, in addition, was not enough. They needed more space. So an external medical center was built at the Bergamo Exhibition Center. So it was a big building used for exhibitions, and Lombardy region, together with the management of the hospitals, they decided to move to this space beds, medical staff, and all the equipment necessary, in a sense, to move COVID patients from the hospitals so that the hospital could focus also on other patients. And then medical staff and nurses dedicated to COVID moved together with the patients to the exhibition center. Not only new medical staff was hired, but the hospital could benefit from the army, not only the Italian army, but also other countries, European countries and non-European countries, including Russia. They sent military contingents to support Bergamo and the hospital and all the logistics around the pandemics. Next slide, please. I will conclude just saying that, as I said before, Bergamo is one of the biggest, the hospital of Bergamo is one of the biggest hospitals in Lombardy, but the entire province is one of the biggest after Milan in Lombardy. So the hospital of Bergamo normally serves approximately 1,200,000 people, but obviously during the pandemics, the number of people and patients that could go to Bergamo Hospital was even higher. And so that is the end of our first best practice.
Thank you. That's really interesting and brings back awful memories of the early days of the pandemic. Okay, so well, Paula, are you going to do?
Yes, I will.
Yeah, why don't you, and then Marcello can do his, and then we'll have a Q&A.
Perfect.
Great.
Okay.
Thank you.
Thanks. So the second good practice that we're going to present represents a system, a coordination system, in particular put in place for patients who could not wait. We are talking about urgent patients, hubs for time-dependent disease. We can start with the slides. Again, we are going to focus in particular on one hospital. Today, we will talk about the Centro Cardiologico Monzino, which is a research hospital mostly focused on cardiovascular disease. We are again at the beginning of the pandemics. It becomes clear that the hospitals are becoming more and more used to treat COVID patients. However, it is clear there is a growing necessity to look after the patients who did not wait. We are talking about chronic patients, and in particular now we are going to focus on patients with cardiovascular disease, people and patients who needed a high level of attention, not only in general, but in particular during this phase. So Lombardy region, we are at the very beginning of the pandemic, so it was the 8th of March, it was a couple of days after the national lockdown, decided to create a system of hubs, which is a system where a few hospitals become hubs, become the center for treating particular disease. In particular, it was decided to designate 4 hubs for cardiovascular diseases in all Lombardy, and the coordination of these hubs was given to the Centro Cardiologico Monzino. The idea of the hub was to be the reference center for all the other hospitals to treat time-dependent patients. In particular, the idea was to have hubs hospital and to follow these patients, but it was important to remember that ideally the patients were supposed to be moved to the hubs were supposed to be negative to COVID. And then there was a system of non-hubs hospital dedicated to treat other diseases, but mostly focused on COVID patients. Okay, next slide, please. So, as said before, the hub centers, in particular for cardiovascular diseases and cardiac surgery, had to provide for the creation of preferential paths for non-COVID emergencies cases. You can see in the image below, there were 4, as I said, big hubs dedicated to cardiovascular disease. What you see in the list on your right, you have 4 big hubs and then a list of other hospitals. The hospital listed, the fact that they had a hub as a reference doesn't mean that they were little small hospitals. They were very big, a very important hospital. It was just a logistical decision to establish a hub, in particular for a certain type of patients and a certain type of disease. The coordination of the 4 hubs at the beginning started, well, within the 4 hubs that established a shared priority list for emergencies. So we are talking about the wide spectrum of cardiovascular diseases, but obviously each hub has its own expertise in a particular treatment. So the 4 hubs, well, the management of the 4 hubs decided to organize a system of shared priorities so that patients could be transferred according to the needs they had. Next slide, please. Okay, besides the collaboration among the 4 hubs hospital, obviously there was the need of collaboration with non-hub hospitals. So the hubs and the non-hub hospitals had a continuous dialogue with regard to patients who needed to be transferred. In particular, the non-hub hospital with a time-dependent patient informed the hub hospital of the number of patients that need to be transferred, the urgency of their cases and their needs. However, it became quite clear in a few days that the hub hospitals were able to receive patients, but there was not enough medical staff to treat them. So it was decided that non-hub hospitals not only were in charge to transfer patients, but also the doctors and the nurses responsible for that particular patients would follow the patients to the hub for that particular surgery and the immediate follow-up. So it was really a system of, it was a big coordination effort among staff, among patients, among data of the patients that to follow the patient from one hospital to the other and then back. To access the Centro Cardiologico Monzino and the other apps, there were strict rules. As I said before, ideally, all patients treated in the hubs were supposed to be COVID negative, but obviously some patients discovered to be COVID positive once they entered the hospital. So Centro Cardiologico Monzino, as well as the other hubs, had to reorganize themselves as well, creating specific wards for COVID positive patients. In the last part, geographical coverage, you will see that despite the situation and despite the number of emergencies due to COVID, a huge number of surgeries were processed. So this is to say that, again, the system has given proof to work properly. And actually, despite the crisis, despite the number of victims, it actually worked really well. Thank you. And now we move to the last presentation, back to normality, remote follow-up activities and recovery plan. So I give the floor to my colleague, Marcello.
Thank you, Paola. Thank you very much. Now I introduce the last good practice and the procedures which were implemented by ASST Spedali Civili di Brescia. It's another hospital located in the city of Brescia, and it's a public hospital and a sister center. What was the context? The context was that during the acute phase of the emergency, the hospital was the largest hospital with COVID patients all over Europe. But the situation after this first surge was in May 2020 was to reopen all ordinary activities and that had been left on hold. And in addition, moreover, there was the need to create a follow-up system to follow, to monitor all COVID patients who were discharged from COVID and the hospital. So this procedure were adopted at the end of the first pandemic phase between May and October 2020. And that allowed an efficient management of reopening of regular activities, services, and monitoring tools for COVID patients, but not only. And yes, those procedures have been implemented by 2 areas of hospital, outpatient area and admission and treatment area of Ospedali Civili. So with regard to outpatient area, in May 2020, the situation was that it was decided by hospital and the area to give priority to patients we needed urgent care. In Italian national healthcare system, urgent care are marked with letter U, with priority within 72 hours, or B, letter B, within 10 days. So the second step with the first reopening was to reschedule all appointments. In particular, the area and the hospital carried out a map of new areas of hospital premises, not only, but also territorial centers which were completely dedicated to COVID patients and then discontinued. Moreover, according to the new social distancing rule, the new appointments were completely rescheduled. Finally, the result was that the ordinary activities, less urgent appointments, were rescheduled and reactivated, and they are marked normally with letter D within 30 days or letter P within 180 days. Concerning then the admission and treatment area, also the context, the situation during the acute phase of emergency was that they saw a decrease of in admission in the surgical area, but in the meanwhile, admission in the medical area are increased. So with the aim to reduce the waiting times for scheduled surgeries, the hospital and also the area adopted an incentive-based method of compensation for medical nursing personnel by extending the numbers of hours and days for additional surgical section. Finally, the follow-up system was really useful not only for COVID patients, but also to avoid the complete interruption of therapeutic and care pathways for chronic patients. So a follow-up system for COVID patients, but also for post-COVID consequences was introduced and implemented and integrated with a management software called Phoenix AMP. And finally, the geographical coverage was really big. The territory was not only the entire province of Galicia, because the hospital continued to receive that patients of the area, but also other provinces of Lombardy and outside the region, due to the monitoring activities that went beyond the region's borders. Thank you for your attention.
Thank you, Marcello and Paolo. That was really interesting, and particularly to see what was happening at the front line, you know, when all eyes were on Italy at that really difficult time. So thank you so much. So I just want to open up for questions. Are there any questions at all? Do you want to put your hand up?
can't see any hand raised. So
I just wanted to ask you, Paola, you had this model of hubs, like specialist hubs. Has that continued? Because I know there is an interest in the UK around, the centres of excellence and hubs for things like trauma and stroke. So is that model continued?
So even before the pandemic, some hospitals were considered, as you were saying, not really hubs. They weren't called hubs. They were called Center of Excellence. So obviously during the emergency, let's say the area of expertise made these hospitals becoming hubs. Of course, now we presented the cardiovascular, the hubs for cardiovascular diseases, but there were hubs for neurological diseases and for other kind of diseases. So they still exist. What is now less practice is this exchange of medical team from one hospital to another. So since there is, thankfully, a lower number of patients, then patients with a particular pathology can be moved to a center of excellence or to a hub. But what is happening now is that the medical team, unless it's for a very specific pathology, they don't follow the patients, so the patients are transferred.
That was the goal.
But yes, but the system continues. Yes.
Yes. Okay, well, that's great. Anyone else with any questions or comments? No. Okay. Well, I would just like to say a huge thank you to all the presenters. I think we've heard some hugely interesting presentations, but quite inspiring stuff that's been done through COVID, and hopefully heads are buzzing about what we could do next and how that best practice might be transferred to other regions. But just before we finish, I'm just going to pass over to Jose Maria Romero Hidalgo, who's the lead partner, who's from the lead partner organisation, say a few closing words on what we're going to do next. So over to you, Jose.
Thank you very much, Pamela. And first of all, I would like to congratulate our partners from Scotland, from DHI, because it was a very interesting workshop. I think all the presentations and all the speakers done a very interesting topic that still face nowadays with the reality of the COVID-19 pandemic. And well, today it was the first of the 3 workshops that it was described in the Tittan project that are good practices to fight against the COVID-19. The next workshop will be done and organized by our Saxon partners. It is expected to be held in end of April. Unfortunately, it will be again online because of COVID-19 restrictions. The pandemic didn't finish at all. And well, the next workshop will be after the Saxon workshop will be in Basque Country, hopefully in person, we will see. And at the end of the project, it is expected to have a final conference to sum up all the good practices and experience here in Santiago de Compostela in Galicia. This meeting was recorded, and all the good practices and contacts of the speakers will be all published in an assessment report that we will try to publish through the social networks of the Tittan project and also in the Tittan project website. And that's all. Just last congratulations and a big thank to our Scottish partners, because you have done a very great job today. Thank you, Cara. Thank you, Pamela.
Thank you, Lizzie. Thanks everybody for participating, and we'll see you at the next one. Great.
See you.
Bye.
Bye-bye.